Now, there's a couple of other points that I want to make, which I think are relevant for chronic fatigue syndromes. First of all, this is a study, we were not involved in this study, but it's a study in which they use infliximab, which is a very powerful anti-inflammatory medication, routinely used for rheumatoid arthritis, a study that they used in treatment-resistant depressed patients. The hypothesis here was that if the depressed patient have high level of inflammation, then perhaps by bringing down the level of inflammation, we can have an antidepressant effect, especially if patients don't respond to routinely available antidepressant. And of course, similar studies have been going on or have been planned in chronic fatigue syndrome around the same principle, that if inflammation is involved in the pathogenesis or the maintenance of symptoms, by tackling inflammation through anti-inflammatory, we should have some therapeutic effect. Now, what the interesting findings about these studies and the lesson to be learned is that not all patients responded to infliximab. In fact, if you looked at all the 60 depressed patients that were randomized to infliximab or placebo, if you look at the overall samples, the effect of the infliximab favors, the clinical trial favors placebo. So if the anti-inflammatory was worse than placebo in the overall sample, this is in effect a negative study. However, what you can also see that by looking only at the subgroup of depressed patients with higher level of inflammation, you get a progressively more effective treatment, a more effective antidepressant action by the anti-inflammatory. So infliximab becomes, if you like, the difference between infliximab and placebo shift toward the left in those who have a very mild level of inflammation above 1 milligram of CRP, even more so in those above 3, and even more so in those above 5. So the lesson which I think is important, not only for depression, but in fact for chronic fatigue syndrome and similar studies, is that there are subpopulation of patients out there. Not all depressed patients have high level of inflammation, so as probably not all patients with chronic fatigue syndrome have a high level of inflammation, and we've discussed this morning how perhaps patients with chronic fatigue syndrome had high level of inflammation at some point, but maybe it's no longer detectable, or those in which it's still detectable or different from the one in which it's not detectable anymore. But most importantly, we need to personalize treatment when we design clinical trials. So one lesson that we can learn that perhaps from which the depression field has been suffering, but the chronic fatigue syndrome doesn't need to suffer, is that if we're going to use an anti-inflammatory, we need to pre-select patients for high level of inflammation rather than just pre-select them for symptoms, or just take all the patients that are available, and personalize the strategy to the presence of the biomarker abnormality that we hypothesize is relevant. And I'm not aware, maybe out there not discussed yet, but I'm not aware of any studies in chronic fatigue syndrome that is pre-selecting patients for a biomarker of inflammation with the intention of using an anti-inflammatory or similar strategies. If you want to use an antioxidant agent, you probably want to look at the one at high level of oxidative stress, and so on and so on. So personalized treatment could be really something that we need to think about in the future for clinical trial. And we discussed this briefly today. As a part of the study that I've illustrated, a subgroup of patients that developed depression during interferon alpha. This is quite a well-known effect that during the 6 months of treatment with interferon alpha, and Neil also mentioned this in his talk, about 30% of patients develop clinically significant depression. It's interesting that this patient then, the depressive symptoms always improve after the interferon alpha stops. So the persistent fatigue is something different, and if you like, it only happens with fatigue. The mood seems to be much more about the current inflammation rather than just a signature of inflammation of the past. But we also wanted to know what happened to this patient that developed depression at the time of the interferon alpha treatment. And so we look at biomarker changes. We looked again at cytokine changes over time, and we looked at transcriptomic changes. So transcriptomics is a technique that allows us to measure many different products in the blood of patients. That gives us an idea of a variety of biological systems in the body. So we again look at biomarker change between 0 and 4 weeks. So, sorry, this arrow should stop here. So 0 and 4 weeks, or between 0 and 24 weeks. And we compare those longitudinal changes in patients who developed depression and patients who did not develop depression. I'll show you only the data 4 weeks because the data 24 weeks are exactly the same. So first of all, I'll show you the cytokines, which are kind of relevant to what we discussed also today with persistent fatigue. So if you look at the whole sample, interleukin-6, as you would expect, because interferon alpha activates the immune system, interleukin-6 goes up with time. So it goes from around 2.6 picogram per ml to almost 3 picogram per ml at 4 weeks and above 3 picogram per ml at 24 weeks. The very small effect, but they are significant, and they are due to the fact that obviously there is an inflammatory stimuli in this patient. But what is more interesting is that at 4 weeks, the patient that developed depression or the patient that don't develop depression increase in their IL-6 level in the same way. So there is no group effect and there is no interact group by treatment effect. So again, a difference between depression and fatigue. Because you will remember from my talk early this morning, the patient that develop acute fatigue and then persistent fatigue have a much steeper increase in interleukin-6 compared to those who don't develop fatigue. So again, you can see a dissociation between the effect of inflammation in relationship with fatigue and the effect of inflammation in relationship with depression in the same group of people. And very similar finding with TNF-alpha, which is another pro-inflammatory cytokine, which actually is not even correlated with fatigue. But in depression, it increases in everybody and it doesn't increase in relationship with the depression. Now you could argue that this may mean that actually, while inflammation is not involved in depression during interferon alpha, which of course it would be counterintuitive because this patient become depressed during interferon alpha. So we then go on to look at mRNA genes, so transcriptomics, to answer broader questions, to answer the questions, okay, maybe the immune activation as measured by cytokines is the same regardless of whether you become depressed or not, but perhaps the sensitivity of the body to that immune activation is different. And this is in fact what we found. So here you can see just very, very kind of broad measurement, which is the number of genes, so the number of, if you like, biological systems that get activated or regulated by interferon alpha in patients that become depressed, patients that don't become depressed, the non-depressed patient, and then in both group of patients. Now the overlapping genes are of course gene related, mostly related to inflammation, and they are activated by interferon alpha in everybody. These parties, there are genes, for example, that have an antiviral action, and that's the reason why interferon alpha is given in the first place to fight the hepatitis C viral infection. But you can also see that the depressed patient activates many more genes, 500 genes, compared to patients that they're not depressed. They only regulate about 70 genes. So in other words, these people here and these people here have the same level of inflammation measured by cytokines, but their body responds to it. But the patient who developed depression responds to this inflammatory stimuli in a much more intense and broad way. And I think this is this is again a lesson that we can learn in our understanding of chronic fatigue syndromes, that perhaps even if we don't see differences by measuring pro-inflammatory cytokines, measuring actual level of inflammation, that doesn't mean that the body of patient respond similarly. It may well be that the body of patient respond differently to the same level of inflammation because patient are just more sensitive to it. And it could be that we're more sensitive at the beginning, as I've shown you in the data this morning. It could be that they're still more sensitive even during after the diagnosis and during the course of the illness. Again, things that are similar or different between depression and chronic fatigue syndromes. Most importantly, lessons that can be learned from depression in order to improve research in chronic fatigue syndrome. Thank you very much.